Hello and welcome to the Laboratory Matters, where we discuss all that matters in a laboratory. Continuing with our course entitled Decoding Diabetes Mellitus in the Laboratory, in the previous module, we learned a little bit about glucose metabolism. We also learned what are the different samples that you can get in the laboratory in which we assess glucose or samples that we can diagnose diabetes mellitus with. Sample collection, transport, we saw an overview. In this module, we're going to learn about the various tests that are used to diagnose and monitor diabetes mellitus. So the various laboratory tests, as most of us are commonly aware, is and the cornerstone of the diagnosis of diabetes mellitus is blood glucose, whether it is fasting blood glucose, postprandial blood glucose, or random blood glucose. This is a very important step in the diagnosis and the monitoring of diabetes. Also important is urine glucose. Oral glucose tolerance test. And one test which has now become almost synonymous with the diagnosis of diabetes is the glycated hemoglobin or HbA1c. Urine albumin, urine creatinine, albumin creatinine ratio, and also a little more specialized tests like insulin fasting, insulin postprandial, C-peptide fasting, C-peptide postprandial. So these are important tests in the diagnosis of diabetes. There are a whole load of tests that you need to use to monitor the disease, monitor the treatment, the problems that the treatment itself can lead to, the problems that diabetes can lead to. So you have a whole package which is used to monitor the disease. So we'll try to go one by one into each of these various tests. We'll start with the estimation of glucose. One of the most common tests that you get in any biochemistry laboratory, however small and however big it is. We use different methods for the quantification of glucose in the plasma sample or serum sample or urine sample or CSF sample. We use machines which range from semi-automated to fully automated to the high-end machines. We use different methodologies. There are two methods which have kind of stood the test, and the most commonly used method today is the hexokinase. Now, what is this hexokinase method? It's a coupled enzyme assay which involves two enzymes. One is hexokinase and the other is glucose 6-phosphate dehydrogenase. Both are important in the metabolism of glucose. So here glucose 6-phosphate, which is formed from glucose and ATP by hexokinase, which is one of the first steps in the Embden-Meyerhof pathway, is oxidized by NAD in a reaction which is catalyzed by glucose 6-phosphate dehydrogenase. So you get NADH, which is quantified spectrophotometrically at 340 nanometer. So it's a coupled enzyme assay using hexokinase and glucose 6-phosphate dehydrogenase, and you measure the end product spectrophotometrically at 340 nanometers. This is an endpoint reaction. So hexokinase is what most laboratories use to estimate glucose in the sample. The other method that is used is glucose oxidase. This enzyme catalyzes the oxidation of glucose to gluconic acid and hydrogen peroxide. Now, hydrogen peroxide which is generated, you can add the enzyme peroxidase and a chromogenic oxygen acceptor. This will result in the formation of a colored compound, which is again measured spectrophotometrically. So you have these two endpoint assays using different enzymes, which ultimately result in the measurement of a colored compound at a given nanometer, at a given wavelength, which is usually 340 nanometer. Now, once you have measured it, we know that the value of or the normal biological reference range changes with age. So you have to give age-specific biological reference ranges wherever they are relevant. And in glucose, it is very relevant. Also, the patient condition. When are you collecting the sample of glucose? So a fasting glucose sample in an adult, the range is 60 to 100 milligram per deciliter. Postprandial, as the name suggests, is 2 hours after a completion of a meal, is 80 to 140 milligram per deciliter. And a random sample, which has no connection with the meal that the patient has eaten, is 80 to 120 milligram per deciliter. So these are values that don't change in an adult patient, whether it is male or female. Now in children, it's 60 to 100. In premature neonates, it is 20 to 60. And in term neonates, it's 30 to 60. Now, all this we're talking about is plasma or serum. That is plasma when it's collected in sodium fluoride and serum when it is collected in a clot activator tube or a serum separator gel tube. Now, when it is measured in whole blood, as we have in glucometers, then it is 65 to 95 milligrams per deciliter. Now, when you measure glucose in CSF, the value is 60% of the plasma value. So it's about 40 to 70 milligrams per deciliter. And in 24 hours urine, it's 1 to 15 milligrams per deciliter. So this reference range changes with the state of the patient or the time of collection of sample, the type of sample, and the age of the patient. So you have different glucose levels, and when you report, it should be with the corresponding age and the corresponding state of the patient and the corresponding sample. That is very important if your report has to have any relevance. Now that is about measuring plasma glucose. What happens in urine glucose? This also you get, urine sugar, urine sugar. We hear this so often in a laboratory. And in the measurement of urine glucose, you have qualitative, you have semi-quantitative, and you have quantitative. So if you remember, the manual method of measuring glucose, which many laboratories still do, is the Benedict's qualitative reagent, okay, where you use the Benedict's reagent and you use the urine containing sugar. You have a little spirit lamp and you add 5 ml of Benedict's reagent to it and you add to it 8 drops of urine. You heat it over the spirit lamp and you observe the change in color in the sediment that you see. So what happens here? The Benedict's qualitative reagent contains cupric ions in alkaline solution. Now the sugar, which acts as a reducing agent, will convert the cupric ion to cuprous ions, which forms yellow cuprous hydroxide, which then becomes red cuprous oxide, depending upon the amount of the reducing agent. And depending upon the change in color from blue to red, we say it is 1 plus, 2 plus, 3 plus, and 4 plus. So this was the method that was used, and we used to only give a qualitative report. Many labs are still using that. Now we've got a little better. We use the commercially available dipstick method. We have done away with this manual method of using the liquid reagent. So here you have glucose, which is estimated by a glucose-specific enzyme, which is glucose oxidase, in a chromogenic assay. So this is using the dipstick, which can have either 10 parameters, or it can have only glucose, or it can have glucose and protein on these plastic strips in which you have little pads, which are specifically coated with the reagent, which is the enzyme and the attached chromogen or the dye. So usually when it's glucose oxidase, it uses dyes like O-tolidine or tetramethylbenzidine. And depending upon the intensity of the color that is developed, this change in color is proportional to the concentration of urine in the concentration of glucose in the urine sample. Now you can either look at the strip visually and report it, or there are semi-automated to fully automated urine analyzers, urine chemistry analyzers, in which if you place the strip, it will read it and it will give you the report, which will say that it is, again, it will grade it from 1 plus to 4 plus, rather from nil to 4 plus, and it will also give you the quantity of glucose that is present in the sample. And the measurement range is between 100 to 250 milligrams per deciliter, depending upon the change in the color. So this is what most labs now use to measure urine glucose. And it is reported as nil to 4 plus. Now, you can get false positive results by contamination of the urine by hydrogen peroxide or a strong oxidizing agent such as hypochlorite or bleach. So, if your containers in which you ask the patient to collect urine has some bleach or some oxidizing agent, you can get a false positive report. A false negative result can occur with large quantities of reducing substances, ketones, ascorbic acid, and salicylates. So these are uh, agents which can give you a false negative report. So you have to, if you're getting false negative and you think that the patient could have, a urine glucose positive, you have to go and check whether the patient is taking vitamin C, whether the patient is taking salicylates, or whether the urine glucose value is very high. So you can do a quantification of the urine glucose. So this is a ubiquitous test and done commonly in all laboratories. It may be part of the urine routine examination. But we have to keep in mind what is the principle. So it is glucose oxidase in a chromogenic assay where there is a change in the color depending upon the concentration of glucose in the urine sample. Now you can also quantitate it in the biochemistry analyzer. In the urine mode, you can run it and you can quantify the urine glucose and that uses either hexokinase or the glucose oxidase method, depending upon which method you are using in your analyzer. You can either, some analyzers will ask you to run it on a urine mode, some analyzers you can even run it as part of the normal serum mode itself. Whatever it is, it uses the same methods that it uses for serum to give you the quantification of urine glucose. So you've quantified the glucose in the plasma, you've quantified the glucose in the urine. Why is it important? If the values are high in the plasma but your urine is normal, that means your kidneys are still working fine. The diabetes has not yet affected your kidneys and you're not passing glucose in the urine. However, if you find that there is a large amount of glucose in the urine, you need to look for any nephropathy or the fact that your diabetes is uncontrolled. The presence of a large amount of glucose in the urine can also lead to frequent urinary tract infections. Now moving on. The other sample in which you're frequently asked to measure glucose is CSF. Now we measure The glucose in the CSF, again in our biochemistry analyzer, and it is usually measured in the same mode as that of plasma or serum. And it uses the same reagent, which is either hexokinase method or glucose oxidase method. One important thing when you're measuring CSF glucose is you should ask for a concurrent plasma glucose. That means when the patient's CSF sample comes to you, you should at the same time ask for a plasma glucose. You should collect a sample in fluoride, you should measure plasma glucose, and you should measure CSF glucose. CSF glucose is usually 60% of plasma glucose if it is estimated at the same time. So you can't measure CSF glucose in the evening and correlate that with a plasma glucose that is measured in the morning. It should be measured at the same time. So it's good clinical practice to perform concurrent measurement of CSF and plasma glucose. This is something you need to keep at the back of your mind, and you need to ask for the patient sample to be sent, a serum sample or a plasma sample to be sent along with the CSF. Many labs don't ask for this, and you just report whatever glucose value you get. So a very high glucose value could be because the patient's plasma glucose was very high. Either patient had a dextrose drip or the patient is a diabetic with uncontrolled sugar. So that is very important for you to correlate, for the clinician to correlate. So you should ask for a sample, venous sample from the patient. Now we move on to another test that is done often, but kind of not done in a very standardized way. Different labs perform the test differently, which is the oral glucose tolerance test, or the OGTT. Now, this test requires certain pre-test conditions. One is you should discontinue, if possible, all medications that affect glucose tolerance. You should estimate this, or you should perform this test after 3 days of an unrestricted diet of at least 150 grams of carbohydrates and exercise. That means you should eat normally, you should do your exercise properly, and then come to do this test. This test should be done after 10 to 16 hours of fasting. It should be done as an outpatient test. It should be done only in ambulatory patients and not in sick patients. It should not be performed in a hospitalized patient or a sick patient. Now, when this patient comes to you in the morning, he should have not exercised at that point. He should come there. He should remain seated. He can drink little bit of water during the course of the test. He should refrain from smoking, and he should remain seated. So you can see lots of these people who will be going around the hospital. They'll say, I'll go for a walk and come back. I need a smoke. I smoke in the morning. So all this is not permitted when you're doing the OGTT test. The patient should preferably be seated outside your phlebotomy room. He can go for a small walk maybe. He can drink sips of water in between. But apart from that, no stress, no on the mobile, no discussing office, business and stuff like that. That is a perfect or an ideal way to do this test. Now, what should you do? The test should again be preferably be performed between 7 a.m. and 9 a.m. because you want the patient to come in fasting. What is it that we administer? Anhydrous or monohydrate glucose, which may or may not be flavored. We prefer to give a slightly flavored glucose because it's easier for the patient to drink it. So you have to weigh 75 grams of glucose, dissolve it in 300 ml of water, and make the patient drink this within 5 minutes. So it's important to follow this part. 75 grams of glucose is weighed, dissolved in 300 ml of water, and the patient should drink it within 5 minutes and then remain seated after that. In non-pregnant adults, it's 75 grams or 1.75 grams per kg body weight up to 75 grams. This is actually the prescribed dose. We give 75 grams for most of the patients. So this is important as the pre-test conditions for the patient. You take 75 grams of glucose, dissolve it in 300 ml of water, mix it well and make the patient drink it within 5 minutes. It's not easy, but you need to do that. Once you give that, before you give the glucose to the patient, you take one fasting sample, one venous sample and a urine glucose sample. Then you give the glucose to the patient, ask the patient to come back after an hour and repeat the same samples. Ask the patient to come back after 2 hours and repeat the same samples. Now, drugs, fasting, diet, anxiety, smoking, physical activity, caffeine, all this can affect the test. Therefore, you have to advise your patient suitably. Now, this is the usual recommended samples that we take. Now, when we do an extended OGTT, you can take half-hour sample, 1.5 hour sample, 2 hours, 2.5 hours and 3 hours. Some people even go up to 5 hours if there is any difficulty in the diagnosis of diabetes. But this is the usual 3 samples that you take plus 3 urine samples that you take when you're doing an OGTT. Sometimes if your clinician wants, he can ask for a 3-hour sample, or else this is the usual samples that we take. In some cases, the clinician can advise a 100-gram OGTT. That's not very commonly done. The usual standard testing is 75 grams of OGTT and you take these samples and you do the test. Now, can you do a glucose challenge test, which is like a screening test for gestational diabetes mellitus? Now, this is done in pregnant females between 24th to 28th week of pregnancy. Now, what is the advantage of doing this is it's a single sample. You don't have to be in a fasting condition because that is difficult for the pregnant woman. Where any time that she comes to see her gynecologist, she can be advised to do this test. And all pregnant women need to be screened between the 24th to 28th week, which is the second trimester, because that is the time that the gestational diabetes is usually presenting and it needs to be evaluated. Now, supposing the patient has a very strong family history, is very obese, is hypertensive, has a family history of diabetes, then you can do it even earlier at the 16th week and then maybe repeat it even in the 3rd trimester. So here we give 50 grams of glucose and 250 ml of water over 5 minutes, and after 1 hour you measure the plasma glucose. If it's less than 140, it's normal. If it's between 140 and 189, it needs further testing with OGTT. And if it's greater than 190, it signifies that the patient has gestational diabetes and needs to be treated. So this is another common test that is performed. It will usually be referred by the obs-gynae department and is done for all pregnant women in the 2nd trimester of pregnancy. Usually we give 50 grams. Sometimes in some institutions they give 75 grams also. Then it is your laboratory practice. Let's move on to another very commonly, or today this test is the one which is used to diagnose diabetes mellitus. Glycated hemoglobin or HbA1c. So what is this test? Glycation is the non-enzymatic addition of a sugar residue to the amino group of proteins. Chromatographic analysis of hemoglobin A, which is the adult hemoglobin, reveals minor hemoglobins like HbA1, HbA1b, HbA1c. Now, HbA1c is formed by the condensation of glucose with the N-terminal valine residue of each beta chain to HbA to form an unstable shift base. Slightly complicated, but what we're trying to tell you here is that the adult hemoglobin is got some minor hemoglobins like HbA1, HbA1b and HbA1c, of which HbA1c is most important because to the N-terminal valent residue of the beta chain, the hemoglobin is made up of alpha and beta chains, to the beta chain, the glucose moiety gets attached and that forms an unstable shift base. So the glucose moiety that is there in your blood is getting attached to the N-terminal valine residue and it forms an irreversible bond. So this glucose that is attached to the hemoglobin can be measured, and if that is high, it means that you have increased glucose in your blood. Now, because it's an irreversible bond and the lifespan of the glucose of the RBC is limited, it gives a very good guideline. Okay, so this is one of the most important tests to diagnose diabetes, and in fact, it is the test today to diagnose diabetes mellitus. Now, an important thing here is that this HbA1c level depends on the RBCs having a normal lifespan. So if in cases of hemolytic anemia, where the RBC lifespan is shortened, the HbA1c level is low and you cannot really depend on those levels. Now, this gives you an average of say 3 months or 3.5 months. What is the average glucose in your blood? But one should know that 50% of the HbA1c or the glycated hemoglobin value is contributed by the glucose levels in the previous month. Now, where I'm coming to is that today when I come to see my diabetologist, my fasting may be normal, my postprandial may be normal, but my HbA1c levels may be high. Because the HbA1c level is not based on what I'm eating today or how much of medication I've taken today, but it's based on what my average glucose level has been over the last 3 months. So I could be normal today, but maybe like 3 weeks ago, I was binging on sweets and my glucose levels were very high. So this average glucose level for the last 3 months gives the doctor a fair idea of how your glucose levels vary with respect to time. So now that we've decided that this is a very good method, especially in a patient who has a normal red cell lifespan, there are certain guidelines. The laboratories should only report HbA1c values that are performed on assays and methodologies which are certified by the NGSP, which is the National Glycohemoglobin Standardization Program, which is traceable to a DCCT reference. So only such machines should be used. You can't, though there may be so many different methods of measuring the glycated hemoglobin, you just can't use any method. You have to use a certified NGSP certified methodology. Now, what is the sample? Whole blood and EDTA, because your guideline here is the hemoglobin. It is seeing how much of glucose is stuck to your hemoglobin. So you can collect it in oxalate or fluoride because you're looking at whole blood. The samples are stable for 1 week when it is refrigerated. So the commonly used sample is whole blood, which is collected in EDTA, and the sample is stable for 1 week when you keep it at 4 degrees centigrade. Now, like I said, the techniques are several. Now, the one method is the charge differences. Okay, so when hemoglobin will migrate along a cartridge. So ion exchange chromatography, high performance liquid chromatography, hemoglobin electrophoresis, isoelectric focusing. Then looking at structural differences, affinity chromatography, immunoassay, and photometry and spectrophotometry. Now, though there are so many methods and quite a few of them have been ratified by the NGSP, the high performance liquid chromatography is one of the most commonly used methods in most laboratories. Apart from affinity chromatography, there are some labs which are using immunoturbidimetry also. So we, like I said, have to use an NGSP certified methodology. I'm not going into the what each methodology is and into the intricate details of each methodology. So when you're reporting glycated hemoglobin, let's for example take that most labs are reporting it using a system which does high performance liquid chromatography. It's expressed as a percentage of the total hemoglobin. So as the hemoglobin moves across charged cartridge, there is an exchange of ions and it will tell you how much of glucose is stuck to your HB A1C moiety, and it will show you a graph, and from that graph the amount of HbA1c that is there will be determined. So it is eluting the various fractions of hemoglobin and a graph is generated, and depending upon the area under the graph the amount of HbA1c will be determined. Now, HbA1c results less than 4% or greater than 15% should be further analyzed for the presence of a variant hemoglobin. This is a drawback with this method, because if there is a variant hemoglobin, that also gives you a peak and you cannot exactly assess which is your glycated hemoglobin. Now, when you're reporting glycated hemoglobin, you should also report what is known as estimated average glucose, which is actually telling you that okay, this is the percentage of hemoglobin that is glycated, and if for this glycated hemoglobin, this will be your average glucose, and that is a calculated parameter calculated using this formula. This should be part of each report, and any value which is greater than 6.5 is suspicious of diabetes mellitus, and or rather is diagnostic today of diabetes mellitus. So this is glycated hemoglobin, which is measured today all over the globe and ubiquitously in most laboratories. Now, if the patient has a shortened lifespan of the red cell, what to do? How are we going to measure the glycated hemoglobin? Or you want to know short-term alterations of blood glucose. Now, there is non-enzymatic attachment of glucose to amino groups of proteins, to other proteins other than hemoglobin. Hemoglobin is also a protein. It can attach to ketoamines like fructosamine. It can attach to serum proteins like albumin or other membrane proteins. So when this glucose attaches to any one of these, the half-life of these proteins is shorter than red cells. So these assays are more sensitive to short-term alterations of blood glucose. And when you want to measure the blood glucose fluctuations over 2 to 3 weeks, which is very important in gestational diabetes mellitus, where I'm not really concerned about what happened in the last 3 months. I'm more concerned in the changes that occur over 2 weeks or 3 weeks, and therefore I use fructosamine or glycated hemoglobin, such kind of tests, though not done very frequently, in somebody whose glucose level is fluctuating, this is a good test to measure the changes in the glucose level over shorter periods of time. And it is a good monitor in gestational diabetes mellitus. The assay can be done again using HPLC, affinity chromatography, or photometry. So there are methods. These assays are done in specialized labs, and you can use them for short-term measurements of glucose short-term changes in the glucose level over 2 to 3. So as we end this module, we will continue the rest of the tests in the next module. We've seen here the more routine tests that are used to diagnose diabetes mellitus, and the two most important among them are the glycated hemoglobin, which needs to be done by NGSP certified methods, and the measurement of glucose either in a fasting state, a postprandial state, or in a random state using either a semi-automated or a fully automated machine, which is of course calibrated and where controls are run regularly using any of the methods which are acceptable, like either the hexokinase or the glucose oxidase method. So the diagnosis of diabetes mellitus is not very difficult but needs to be done properly using the right kind of tests. So we'll close this module with this, and as we move on to the other tests in module 3, we will go over this module, relearn what are the important things while doing glycated hemoglobin or glucose testing in your laboratory. So until module 3, please go on learning all that matters in a laboratory. Thank you from the Laboratory Matters.